All right, we do have a packed schedule, so I think we should go ahead and get started. Hi, everyone. Welcome to Improving Childbirth Outcomes by Optimizing the Use of Uterotonics, Sharing Learning, and Tools. During this webinar, we are offering simultaneous interpretation in English and French. To choose your language, click on the globe icon at the bottom of your screen. You can also view the slides in either English or French. At the top of your screen, you should see options to view the slides in English or French. Next slide, please. Next slide, please. So this webinar is hosted by the USAID-funded Momentum Project, which is a suite of awards working in more than 30 countries to improve the health and well-being of individuals, families, and communities, with the ultimate goal of accelerating the reduction of maternal, newborn, and child death and disability. Today, we will have speakers representing 4 of the centrally managed awards: Momentum Country and Global Leadership, Momentum Private Healthcare Delivery, Momentum Safe Surgery and Family Planning and Obstetrics, and finally, Momentum Knowledge Accelerator, the award I, Francesca Alvarez, am representing and support as a policy advisor. It's a pleasure to be with you all today, and we're very excited about your participation in today's webinar. Next slide, please. Before we get started, I have a few quick announcements. First, please feel free to introduce yourself in the chat. Second, as we proceed, if you have any questions for the panelists, we encourage you to submit them through the Q&A function at the bottom of your screen. You can also upvote the questions that you share interest in the Q&A function as well. Our panelists and their colleagues will be providing written responses to questions in that space. Feel free to use the regular chat space for any general comments or reflections during the event. Next slide, please. Since I know participants are still joining, I want to mention once more that you can view the slides in either English or French. So the options might be appearing a little bit differently for you on your screen, but at the top middle of your screen, you can select View Options and you will see 2 choices, English and French. Next slide. We are also offering simultaneous interpretation in English and French. To choose your language, click on the globe icon at the bottom of your screen. Everyone attending should select a language to be sure you hear all presenters. Please note that we do not recommend selecting mute original audio, as you will only hear the interpreted language and you may miss out on a panelist speaking. Next slide, please. And these are the same instructions for choosing a language written in French. Lastly, this webinar is being recorded. We will be sending out the slides and recording shortly after the event to all who registered. And now I'd like to introduce our esteemed moderator, Deborah or Debbie Armbruster. Debbie is a senior maternal and newborn health advisor with the United States Agency for International Development's Bureau for Global Health. Thank you, Debbie, for moderating today, and over to you. Debbie, you're on mute.
Very sorry about that. So let's start again. Thank you to Francesca for setting the stage and for that introduction. And I want to start with a few thank yous to colleagues who helped start this work several years ago. Lauren Wright, now a USAID health officer in Benin, Richard Chu, who's moved from working with us to a new position at AID, Joshua George, and a resident OB-GYN at that time, our Madagascar USAID and UNFPA colleagues, and an invaluable advisor, Sachin Gupta of the USAID mission, India mission. We're here today to present and discuss exciting work and efforts by a number of the USAID's Momentum Suite projects to improve childbirth outcomes through the use of uterotonic medications. Uterotonic medications are powerful and critical tools in preventing and treating postpartum hemorrhage, or PPH, a leading cause of maternal mortality, which I'm sure you all know. When used after birth, these medications, oxytocin, misoprostol, heat-stable carbetocin, are very safe and can prevent up to 60 to 70% of postpartum hemorrhage. Some uterotonic medications can also be used to start or strengthen a woman's labor. Oxytocin.
Debbie, it looks like you're on mute once again.
Well, I don't know how that happened. Sorry, I didn't push it. Okay, sorry. Do you know? Anyway, let me start with some medications. Some uterotonic medications can only be used to strengthen a woman's labor. Oxytocin for induction and augmentation, misoprostol for induction, and never use heat-stable carbetocin for any of these purposes. But then these medications must be used for their intended purpose and require considerable safeguards to avoid any negative health effects for women and the fetus. Swell and Miller's et al.'s framing of too little, too late, and too much, too soon can be applicable to the use of uterotonics, since there is concern that for preventing and treating PPH, uterotonics are used too little and too late. But let's make sure we use quality assured uterotonics. Then the maxim too much, too soon can describe the use of uterotonics for induction and augmentation when there is unnecessary and non-evidence-based use, recognizing that these interventions can be life-saving when used appropriately, but harmful when applied routinely or overused. Too much too soon can also describe routine over-medicalization of normal pregnancy and birth, which is regularly identified as a serious issue in the Latin American region. We collectively strive to ensure high-quality care and appropriate medication use. And today we will hear 4 presentations from the Momentum Suite that are seeking to understand, document, and optimize the use of uterotonic medications. On induction and augmentation, the presenters will share some general information about uterotonics and their use during induction and augmentation, the risks involved in their use, labor induction and augmentation practices in India and South Asia, with some outcome data on stillbirth, neonatal mortality, and the use of cesarean.
Debbie, I'm sorry, it looks like you unintentionally went on mute once more.
I'm not hitting that button, so I don't know what's going on. So sorry about that. Okay, thank you for letting me know. On prevention and treatment of PPH, there will be presentations on a global survey of national programs for the prevention and management of PPH and hypertensive disorders of pregnancy, and an evaluation framework for heat-stable carbetocin, a newer medication to prevent postpartum hemorrhage that's being rolled out in Madagascar. Our plan for this webinar is to start with short presentations from the various awards. As they are presenting, as Francesca said, please feel free to add questions to the Q&A tab at the bottom of your screen and any comments or reflections in the chat. Colleagues of presenters who are on the call can feel free to respond to the Q&A and participate via chat as well. Following presentations, participants will have the opportunity to engage with experts during a Q&A session, but we will be taking the questions. Unfortunately, you won't get to speak. And we will have a discussion with the full group to dig in deeper and reflect on the lessons learned from this work. Though we have time constraints, make sure you write your questions because we'll create an FAQ document to answer all of them if we don't get to them. And with that, I turn it over to Megan Marks Delaney, research scientist with Ariadne Labs, representing the Momentum Knowledge Accelerator. Over to you, Megan.
Wonderful. Thanks so much, Debbie. I'm excited to be here today to present this work on behalf of the many colleagues and organizational representatives from across India who've contributed their time and insights to understanding this story around uterotonics. As part of Momentum Knowledge Accelerator, we were asked to consolidate and summarize the current research on uterotonic use for labor induction and augmentation with a focus in India. We spoke with a series of stakeholders across sectors to ensure the most up-to-date information could be included. Next slide. To start, I want to give you a little bit of background. Debbie started, and this is great. I'll just add to that. Next slide, please. So what are uterotonics? Uterotonics are medication that cause the uterus to contract. Next slide. They are absolutely a critical tool for preventing and treating PPH, postpartum hemorrhage. Postpartum hemorrhage is the leading cause of maternal death globally. Uterotonics can also be safely and effectively used to start or induce and augment or strengthen labor. Next slide. So there's a key difference in uterotonic use before and after delivery. The WHO says that every woman should get uterotonics after delivery to prevent hemorrhage. That's the standard of care. It's safe and effective without close monitoring. However, not every woman should have labor medically induced and augmented, as these medications are risky to use during labor. Next slide. So proper monitoring and having sufficient staff to ensure women are never left unattended and have the skilled staff who can assess the patient and recognize and act in the event of distress of the mom or fetus, that's really critical to using these medications safely, like so many other medications, right? Next slide. There's many health consequences of uterotonic misuse during labor. The main ones are birth asphyxia, stillbirth, and early neonatal death for the baby, as well as uterine rupture and increasing the need for emergency cesareans on the part of the mom. Next slide. Birth asphyxia, just a little bit of a background. I'm sure many of you on the call know more than I do, but it's mostly breathing failure. It's a leading cause of stillbirth and newborn death. And while many factors can lead to asphyxia, the judicious use of uterotonics during labor is a factor. Next slide. Cesareans increase the risk of complications and increase cost. Inducing labor with uterotonics without safeguards like gestational dating to ensure that the woman is at term, standard protocols, active monitoring can increase the need for emergency cesareans. Next slide. The biggest harms are really for the fetus or newborn. A recent systematic review found an association between labor augmentation and stillbirth and day one mortality, among other key outcomes. Next slide. So the bottom line, reducing unindicated, unmonitored routine use of uterotonics during labor can save lives. Next slide. Now, as we know, India is a very influential force in maternal and neonatal care globally. Next slide. There's really an opportunity to lead change on this issue around over-medicalization of childbirth. Given the current forward-thinking quality improvement programs that are in existence and thriving in India, efforts like Lakshya, Dakshata, India is really well positioned to lead the effort in reducing preventable morbidity and mortality. And this is why this is one of the countries that we were asked to focus on initially. Next slide. So far, the story seems pretty straightforward, related to the potential harms of not using a medication correctly. However, unmonitored uterotonic use remains really common. How common is it? My colleague, my Momentum colleague, will tell you a little bit more from their systematic review in the following presentation. But you can see that there's very wide variation for both labor induction and augmentation across India. A recent global systematic review found that India had among the highest rates of overuse. Next slide. So why is the question? Why is it so high if we know that it causes harm? From both the documented literature and our key informant interviews, there are a few main categories driving the use among healthcare workers. One, legacy practices. It's the way things have always been done, and it comes down a lot past practitioner through medical colleges. Another is logistics, to save time due to limited beds and limited staffing and to be able to move people along quickly. There's demand from patients and families, and many of the practitioners want to cater to that demand to give them the experience that they expect. And there's the little perception of harm. Next slide. Patient and families are also seeing uterotonic use during labor is very positive, as any care is often seen as good care, and IV drips have a positive understanding in many of the places. And there's just low perception of harm. No one thinks it's going to do any harm. Next slide. At the current scale of use in India, though, irrational use of Uterotonics can have a major health effect. Next slide. So you might ask, where's the guidelines? There are great guidelines out there. There's a series of global and India-specific guidelines around labor augmentation and induction, but adherence is limited. There were many gaps that were identified during both in the literature and during the stakeholder interviews, some related to protocol, standardization, and other just different definitions within the guidelines themselves. Next slide. Despite the potential for harm, there's consistently casual use patterns. One of the things said during stakeholder interviews that really resonated with many people is, it's harmful, but a little bit might not do too much harm. We don't measure ingredients when we cook. It's all about a little bit of this and a little bit of that. And that attitude really extends to medication administration. Next slide. So the next steps. I know that this is a short presentation. Next slide. With the consolidation of these findings, it's important to recognize what actions are now needed to really move ahead with ending this preventable harm. One of the things is really starting to build consensus and awareness around the negative effects of uterotonics. To consolidate a research agenda, again, as Dr. Giovanni will talk a little bit more about, and really standardize. Studies are often designed so that they can't be compared one to the other, and it really limits how we can understand the practices. Address the ambiguities that exist in the guidelines. Think about strategies to improve the safety, given staffing patterns. Is there any way to make this current practice safer? And then to secure joint support from across public, private sector, and community groups to align messages. Next slide. Oh, sorry, I skipped ahead. And final. I'm excited to have the opportunity to really present today, and I look forward to any questions that you have. And I turn this back over to Debbie.
So thanks so much, Megan. As always, great presentation. And next we're going to have Dr. Giovanni, who's an OB-GYN from the obstetrics and gynecologist from the London School of Hygiene and Tropical Medicine. And he's been working with the Safe Surgery Project, MSSFPO, that's part of the Momentum Suites. Over to you, Giovanni. Thanks so much.
Thank you, Deborah, for the kind introduction. It's my pleasure. I'm all excited to be sharing the results of our systematic review on augmentation and induction of labor in India. To begin with, I would like to acknowledge the huge contribution of Dr. Louis Tenade, Dr. Evgeny Pritov, and Dr. Vandana to our work. Next slide, please. This is the outline of my talk. Next, please. It's well known that the maternal and fetal outcome are significantly poorer when labor is inappropriately induced or augmented. The aims of our review were to describe the use of pharmaceutical induction and augmentation and assess maternal and fetal outcomes. We also aim at identifying the prevalence of augmentation and induction non-adherent to the World Health Organization guidelines. And finally, we wanted to describe the patient experiences of induction and augmentation. Next slide, please. Regarding our research strategy, we retrieved resources, both published and unpublished, from 3 dozen of databases. The target period ranged from 2011 to 2022. We included resources reporting on primary findings of women who underwent induction or augmentation or labor for viable gestation as defined by individual study protocols. Next slide, please. This prima flowchart illustrates the inclusion of the 64 studies we retained, among which 59 had a quantitative design. Next slide, please. The distribution of studies per year of publication is shown on this graph. Next. One of our main findings was that many studies have been published on augmentation and induction, both globally and in India. Indian studies included in our review primarily took place in public health facilities and were conducted across multiple regions and states in the country. We found wide variations in measurement and sample sizes, including non-standard measurement that precluded strong conclusion and a meta-analysis. Slide. This slide and the next one, next please, illustrate the distribution of the studies per Indian region and territories and per type of setting. Next. We also found a huge variation in the practices, namely the protocol and regimens used for induction and augmentation. The prevalence of augmentation was also quite variable across studies, ranging from 3 to 87%. Another interesting finding is that augmentation was significantly more common for induced labor than for spontaneous labors. None of the study reported on the time elapsed between the last dose of induction agent and the beginning of the augmentation protocol. Next slide, please. This slide and the two that will follow describes the augmentation and induction practices that are not in line with the World Health Organization standards and guidelines. The quantitative studies reveal that 1 in 4 women receive oxytocin before even reaching the health facilities. Among women giving birth at home, 3/4 receive an augmentation drug. Up to 25 women undergoing augmentation of labor in health facilities are administered augmentation agent through the wrong way, namely intramuscularly. Regarding the monitoring that Megan just mentioned, most women are either unmonitored or poorly monitored during augmentation protocols, and this includes absence of a hepatograph in up to 60% of cases and infrequent checks of fetal heart rate. In a study conducted in 60 primary healthcare facilities, reported that half of augmentation protocols are not aligned with WHO standards. Next slide, please. Qualitative studies reveal that decisions to augment labor are commonly not supported by medical and clear indications, and augmentation is commonly conducted in inappropriate settings. The process of augmentation is marked by its quasi-systematic use by care provider and its implementation by unskilled providers. Pain is often used as a monitoring indicator, which is wrong. Next slide. We identified a couple of drivers of the high rates of augmentation reported. On providers' side, augmentation is used as a method to deal with overcrowded labor and delivery wards. On the community side, augmentation is perceived as a sign of high quality labor, and that drives the high demand for the procedure. Next slide. Here are our key messages. Augmentation and induction are very common irrespective of the place of birth in India. Many practices reported in the included studies were non-adherent to WHO and Indian guidelines, and the quality of care gaps reflect normative and knowledge challenges across the health pyramid. Next slide. We acknowledge that our findings might not reflect current emergency practices in a setting where newly published guidelines are available for improved practices. Next. This QR code links to the fact sheet published after the review. Next. Thank you for listening. It was an honor to be sharing this with you. If you have questions, feel free to ask. Over.
Thanks so much, Giovanni. Next, we're going to be hearing from Suzanne Stalls, who's the Director of the Maternal and Newborn Health for JPIGO for the Momentum Country and Global Leadership Program. And then with Gaurav Sharma, who's the Principal Technical Advisor with JPIGO for Momentum's Private Healthcare Delivery Project. Over to you, Suzanne and Gaurav.
Thanks so much, Debbie, and welcome everyone to our webinar today. Good morning, good afternoon. What we'd like to share with you today are the results of a 2022 global survey that we undertook looking at national programs, policies, and guidelines for the prevention and management of PPH and hypertensive disorders of pregnancy. Next slide, please. So what we'll be looking at today are our backgrounds and methods, our findings, and then ultimately the summary of those findings and recommendations for ways forward. Next slide, please. Next slide, please. So our background presents data that is unfortunately very familiar for all of us in that the direct causes of maternal deaths account for nearly 75% of all maternal deaths, with hemorrhage leading at 27.1%. Clearly, the predominant feature of maternal mortality. So in 2011 and 2012, USAID and MCHIP undertook surveys to look at national programs for reducing maternal mortality from PPH and preeclampsia. Since that time, there have been many very critical updates on global guidance, and what we wanted to do was look at how those updates have been incorporated. We also wanted to look at the extent to which policies, commodities, quality of care provided in private sector and the public sector coincided with those updates and how they've been integrated. And then additionally, we are aiming to understand the role of professional associations in policy development and whether those updated guidelines are integrated into national education and training curricula. Next slide, please. So our methods, the timeline was January through May of 2022. The survey was in 31 countries. It was a sampling of USAID priority countries, countries with momentum presence, UNFPA priority countries. The survey instrument was developed and validated through the Postpartum Hemorrhage Community of Practice, the USAID Maternal Health Team, UNFPA, and the JPIGO Maternal and Newborn Health Team. The data collection was led by JPIGO, except in 7 LAC countries where UNFPA led the process, and our data analysis utilized Power BI and Excel to develop composite scores, and then also looking for the thematic analysis of qualitative data. And now I'd like to turn it over to my colleague. Next slide, please. Gaurav Sharma for discussion of findings.
Thank you. Thank you, Suzanne. Next slide. So the first theme we looked at was essential drug availability, and overall the rates of essential drugs for PPH are generally reported as high, and all countries oxytocin has been the gold standard medication for PPH prevention and treatment for decades. Not shown here, but there was good progress in comparing oxytocin availability between the 2011 and the 2022 survey. And it's clear that there have been improvements in all 3 areas. Oxytocin is more regularly available. That is more than 80% of the time at public sector facilities. Oxytocin is being provided free of cost at public sector facilities, and there are less frequent stockouts of oxytocin compared to 2011. As you can see in the graph shown here, there's still a lot to be done to improve the availability of quality assured drugs. It's also encouraging to note that the availability of misoprostol over these past 10 years has increased quite a lot. So that was one promising finding. Next slide. For the national guidelines, as you can see in the graph, more than half of the countries reported that all WHO recommendations have been included in the national guidelines. Most countries scored 100% for using oxytocin as the preferred uterotonic, having a policy for safe blood transfusion, for active management of third stage of labor, with a policy updated to include immediate use of uterotonic. Some of the newer interventions like the UBT, tranexamic acid, umbilical vein injection, those things are still lacking, but overall, I think over the past 10 years, there's been good progress. And like I already mentioned, misoprostol has been scaled up successfully. In 2011, we were only asking questions of whether it had been introduced, but now it's on the EML for 97% of the countries and regularly available in 60% of all countries surveyed. Next slide. This third theme was on quality and procurement. And as you can see in this map, the scores received by countries, the composite score received by countries was varied. And overall, quality, storage, and safety are still challenges across both sectors that need to be improved. And some countries scored higher rates, but some not as high. And this is a lot to cover in a short amount of time, but I encourage you to read the full report. With that, next slide, and let me pass it back to Suzanne.
Thanks, Gaurav. And so with our fourth theme, what we looked at was the midwifery scope of practice and midwives as the frontline healthcare providers in many, many settings throughout the world. We wanted to know if their scope of practice had been updated to reflect these most recent guidelines and global initiatives. What we found is unfortunate in the sense that, as you can see in this graph, that the incorporation and usage of UBT and anti-shock garment has not been incorporated to the same extent within those scope of practice documents for midwives, as has manual removal of placenta, TXA, and then loading dose of mag sulfate. Next slide, please. We also wanted to look at to what extent both pre-service and in-service curricula had been updated to include the newest global evidence and best practices. And most countries reported that the pre-service and in-service curricula had been updated. By and large, private sector lags behind in providing those updated or utilizing those updated guidelines. And so what we recognize then that this is something that should be paid more attention to, and it's definitely a bottleneck. Next slide, please. The national reporting on MNH indicators was really heartening to see, because what we saw was considerable improvement. 74% of the countries now report on the use of Uterotonics as compared to 43% in 2012. And then also 87% of countries are reporting women with severe preeclampsia, eclampsia, as opposed to 51% in 2012. Next slide, please. So the qualitative aspect of this survey was really consulting with those in the country who participated in the survey to understand what they saw as bottlenecks and scale up opportunities. We really kind of consolidated that feedback.
So sorry to interrupt, but we're running behind. If you could please wrap up in the next 30 seconds, that would help keep us on track. Thank you.
Thank you. So as you can see, those are focused on public and private sector collaboration, quality assurance, and quality improvement as areas for opportunity. And back to Gaurav for his conclusion. Thank you.
Thanks, and sorry, this is a short amount of time. Just next slide. So just to kind of wrap up, we have a few key takeaways, which is we need to still work on prioritizing integration of guidelines and amplify the dissemination of the guidelines. Suzanne talked about the importance of working more closely with professional associations and the private sector. A midwife scope of practice, especially for two things, the manual removal of placenta and diagnosing preeclampsia, eclampsia, giving a loading dose of MagSalf was a challenge. So we need to make sure midwifery scope of practice is in line with the ICM competencies. And we need to keep working with both public and private sectors in lots of different areas. Next slide. So I will not go into, next slide, please. So I'll not go into details of the call to action, but we identified several bottlenecks, several interventions and opportunities for countries to drive action towards reducing preventable deaths from PPH. The full report has all of these details and also country briefs with data for 31 countries. So I encourage you to look at that in detail, and please do get in touch with us if we can support with anything. Thank you so much. Over to you, Debbie.
Hi there again. So apologies for I'll come back over here. So next we're going to go back to Megan Marks Delaney, and she's going to wrap up with the last presentation about the heat stable carbetocin and the evaluation framework that's currently in Madagascar. Over to you, Megan.
Wonderful. Thanks, Debbie. So now I'd like to tell you a totally different story about a uterotonics related effort addressing the use of uterotonic after delivery to prevent postpartum hemorrhage. In partnership with the Ministry of Public Health of Madagascar, UNFPA, the USAID mission in Madagascar, we've developed a proposed evaluation strategy to learn from Madagascar's introduction of heat-stable carbetocin. Next. So I'll share a little background about heat-stable carbetocin, about the HSC, that's how we abbreviate it, rollout in Madagascar, and the proposed evaluation strategy that was developed. Next slide. And you can skip that one too. As we know, we've heard many times, postpartum hemorrhage is a major cause of maternal death, and uterotonic medications are a critical prevention strategy. Next slide. So there's absolutely global excitement for this new medication to treat PPH. It was found to be equally as effective as oxytocin, which is the longtime standard of care and doesn't need refrigeration to remain potent, which gives it a huge advantage over oxytocin in many facilities and health systems where cold chain maintenance is difficult and expensive. In 2019, it was added to the WHO essential medication list, and this is all great news. Next slide. Better medications are great, but complexity can also be confusing, especially as the evidence on HSC is evolving. I'm a nurse, and I know that changing new complexities on top of existing workloads can be intimidating. This table was adapted from the 2022 Tranedol systematic review on how to use HSC and TXA in low resource settings. And it really spoke to me, different drugs for different settings, different drugs for prevention versus treatment. It's a lot to internalize. Next slide. And then there's different indications of HSC and oxytocin, and they're not interchangeable for each one of those indications, especially around induction and augmentation. And the evidence is still developing. There's trials underway to use HSC in PPH treatment, so that's likely to change in the future. Next slide. So Madagascar is an early adopter on introducing HSC, and given the importance of this innovation, implementation research is really, really important. Next slide. Learnings from Madagascar can really contribute to the global body of knowledge and can be used to inform the country's own scale-up efforts as well as other scale-up efforts. There's other implementation research on HSC that is coming out month over month, which is exciting, and I think this is an additional way to contribute. Next slide. I can share a little bit about the HSC rollout in Madagascar. Next slide. As I mentioned, in 2019, HSC was added to the essential medication list. In 2021, the National Action Plan for New and Less Used Commodities was developed. And then from 21 to 23, National approval was gained for HSC. That's a critical step. Distribution to the first 5 regions, and then the initial training of trainers occurred. We all met this last October of 23 stakeholders to reflect on their experience and to make plans to achieve a nationwide rollout by 2026. Next slide. During the convening, much was discussed. There were some great successes with HSC that were mentioned, overcoming cold chain challenges, really the empowerment that people felt of having options with Uterotonics within the facility. And then challenges of some of the reluctance and the insufficient feeling about insufficient training and unmet need within the community. Now, during this convening, as we had an eye towards an evaluation, we identified existing data sources that could be leveraged to minimize the burden of data collection wherever possible in order to kind of be able to learn without a huge amount of extra burden and effort. Next slide, please. So during the convening, we discussed what learning and research questions might be the most useful within Madagascar and within a larger community. Next slide. Next slide. Oh, sorry. Can you go back? Sorry about that. Some of the key research questions included if HSC introduction was really improving PPH prevention in the country, was one of the key things. Is this addition, all this effort, are we preventing more hemorrhage? The second is really, was there any harm given the complexity of adding a new medication and potential contraindications during augmentation and induction? And then really, what's the minimal effort needed to sustain use of this drug and this new behavior of using the drug? Next slide. We used the RE-AIM framework, which is a common implementation science evaluation framework, to identify key dimensions for the evaluation. I know the text might be small for some, but the R, which stands for reach, is really kind of thinking about, okay, what proportion of women are even correctly getting HSC? E for effectiveness. What are the perceptions around effectiveness or harm? This is not going to be, we're not recommending an effectiveness trial. We have that already. But just kind of getting people, because that can really drive behavior change. Adoption, how many facilities are even able to and willing to integrate HSC across all of the regions? Implementation, what is actually being done at the front lines? What does the training look like? What does the leaflet look like? And then maintenance, what does all this look like over time? Next slide. We built out the framework, taking into account what data would be easily available and of reasonable quality. And thinking through when it would be important to have data, for example, before the next big expansion step. This evaluation framework is available online for anyone interested in considering or adapting it for other contexts. Next slide. The ideal timeline would be to use the framework. The ideal time would be to use this framework over time, really thinking about around 3 months. Is it even happening? Has this started around 12 months? What can we learn before we scale to the next 7 regions? And then around 24 months, is this still sustained? Is all of our effort that we put into this continuing after the initial push? Next slide. Oh, no. And next slide. I realized that this was a very fast presentation, but here's my contact information. I'm always happy to discuss this further if there's any additional questions or areas for discussion. And with that, Debbie, I'll turn it back to you.
Thanks, Megan. Great presentations by everybody. So now we have a question and answer session. I would encourage folks to look in the Q&A tab because a couple of them have been answered. We do have a couple here. One of them is a question, and I'll find out who would like to answer this. Is your work addressing the option of promoting safer labor induction with Foley catheter balloon rather than Uterotonics? So I think basically it's asking, did we include that or did we address that option during the work on induction and augmentation? Who would like to take that question?
I'm happy to take that, Debbie.
Sure. Go ahead.
So the focus of our review was really on uterotonic use and the medication side of things. I think it's an absolutely important option to enter in, especially as we start to think about solutions or alternatives, because I think always telling people, well, you have this tool, it's pretty good, and now you can't use it, and we're not giving you anything else. And I think considering other options to bring in and what is evidence-based and what could be a safer option for people is absolutely something to consider. So thank you for that.
Yeah, I would ask whether Giovanni, if you had any response you would like to provide as well. Okay, maybe not. I guess I would say I do think that the systematic review. Oh, go ahead, Giovanni.
Yeah, are you hearing me now?
Yes, now we're hearing you. Thank you.
Okay, sorry for that. Our review examined the use of drugs, induction and augmentation drug. But we found that in several studies, drugs were combined with Foley's catheter in the protocols. So while it is important, we didn't really capture the use of Foley's as a unique induction technique.
Okay, thanks so much. We have another question about how to strengthen engagement of the male and family planning programs where there are a lot of obstacles. Does anybody have answers to that? I think maybe we'll have to think about that one and we'll get back to the author of that question. And we'll move to, it says, we're curious to know if the heat-stable carbetocin rollout in Madagascar is entirely product-focused or incorporates other system strengthening interventions. Megan, over to you, and then I can also help a little, or we'll see if anybody else on the line can. Over.
Sure. Yeah, I would welcome you, Debbie, or other colleagues who might be here with us to talk a little bit more about this introduction. My understanding of the introduction is that it's rolling out as part of a PPH package. So it's not just going around doing one training on one drug, because as you know, there's a lot developing in PPH and training resources are limited. And so I think it's kind of an overall package that goes along with drug introduction and availability being increased in the facilities, as well as training and a leaflet that will go along with that. But Debbie or anyone else, please chime in.
No, I think that was a great answer. I'm afraid I haven't been able to look through the participants to see if we have any of our colleagues from Madagascar, but if anybody's on the line and wants to go off mute and speak up or put something in the chat, that would be most welcome. Anybody? Now, I have to admit, I'm not sure you can come off mute in terms of the rules of this webinar. But if we have anybody, oh, okay. Chari, let's see. Francesca, can you allow that person to speak?
Yes, Joyce, you should be able to speak now.
I'm not hearing anything.
I think Debbie will wait for the translation. I think it might be being translated.
Okay.
Yeah, can you hear me now?
Yes, thank you.
Yeah, my contribution was I do agree with the presenter on Madagascar's best case study in terms of the utilization of heat-stable carbetocin. Indeed, in this part of the world, we are still having challenges of procuring heat-stable carbetocin, but we do appreciate that in terms of maternal mortality reduction, especially associated with the PPH, I think it's a solution to this, especially within Sub-Saharan Africa, and more importantly, for the low-income countries like Kenya or within the East Africa community. So I wish if the outcome of Madagascar as a case study can be scaled up to countries like Kenya, Uganda, and mostly the East Africa, so that we see on what will be the gap in terms of the availability of the product. Number two, I don't know in terms of the procurement, what happened post the donor. Are they going to have the patency ending, and are they going to have its stable carbetocin in generic form? Because I understand that the current one is still the originator, and perhaps someone can share with us that what's going to happen. How does the future look like? Is it going to be because generic version likely to maybe come down? Otherwise, thank you very much, and I think it is a solution towards maternal mortality cases associated with PPH. Thank you.
Thank you so much. I think what we'll have to do is get to the manufacturers about generics or put that out. I don't think we're a group that can answer that question, but good points. I think you've made some very good points there. I think our next question is about how are you addressing how are you addressing heat stable carbetocin distribution challenges to facilities? So I'm going to take that one in the sense that, what we've presented today is an evaluation framework for the work that's going on in Madagascar. What we can do is we can send this question on to our colleagues in Madagascar to respond how they're working on the distribution. And I do think there are some other countries that are also involved in working on distribution and use of heat stable carbetocin. So I think as a global work group, we will try to get some answers for you, but I don't think that we have the answers as part of this webinar. And thank you for your interest, though. And then this last question here, are there any guidelines for PPH in humanitarian settings with very limited resources? Do we have anyone who wants to speak to that?
Debbie,
Suzanne?
one thing I think we might just add that we anticipate the PPH guidelines from WHO at the end of 2024, 2025, and I think that will be part of what we can use to kind of look at how we might best fashion a response for humanitarian settings. So I think all of us are waiting with bated breath for those guidelines.
So, and I would also say, as part of the Momentum Suites, we do have one project that is working in humanitarian settings. Unfortunately, they're not represented here. And I think we might be able to speak with them to see if they're doing any particular work around humanitarian settings. But, one of the things we do recognize is that the issue of heat stability is particularly important, and the ability to get refrigeration is going to be much more difficult in terms of use of oxytocin. So these other options really start looking better. So we really do appreciate that. I think our last question here, because we need to move on to, well, I think maybe these last two questions here will hold, and we'll try to get back to you in writing with answers, because I do have some questions that I need to ask the panelists. And I think we need to move there given our time constraints. So I want to start with a question to Megan as our double presenter. And because you presented on both induction augmentation and PPH prevention. What actions can participants of this event today take to promote the appropriate use of uterotonic medications? What can program implementers, researchers, advocates, and donors do following this event? Over to you.
Thanks, Debbie, for that question. I think thinking about uterotonics, they are absolutely a key class of medications, and they play a major role in obstetrics. And so having the medications available is absolutely a critical step. But ensuring the appropriate use is really what's needed to reduce mortality. And that really requires sustained effort and sustained resources. Thinking about HSC as it rolls out globally, it's important to share learnings about effective uptake strategies that can be sustained by individual health ministries without additional outside help. And I think for the labor augmentation and induction, especially as we learn so much about the situation in India, I think additional or new strategies are really needed to think about how to change behavior and sustain that behavior change over time. Over to you.
Great. So now I'm going to turn to, thanks so much, Megan, over to Giovanni. What are the challenges implementers may face when seeking to improve appropriate use of uterotonic medications in labor augmentation and induction? Over to you.
Thank you. Indeed, implementing is key, as Megan just flagged. And in my opinion, the challenges lie in 4, 5, 6 categories. The first one is the availability of context-relevant guidelines that are to be disseminated. And the second is that for proper dissemination, the context should be receptive and appropriate. And under that second challenge, I see environmental pressure with families and communities pushing for increased use of augmentation, organizational culture of routine, non-medically indicated augmentation, and a possible mismatch between facility managers and clinicians, the frontline those giving oxytocin. The third challenge is the multi-sectorial approach to make sure that while we are ensuring that providers follow the guidelines and sustain change implemented, communities are engaged to shift from the misconception about augmentation and induction. The next challenge will be strong leadership, political and bold at all the levels of the health system. Finally, last but not least, I would say finances. Funds should be secure for scaling up those new practices and guidelines. Thank you. Over.
Thanks so much, Giovanni. Really appreciate it. Now, quickly over to Suzanne and Gaurav. Apologies because time constraints are getting to you guys. I should have put you first. What are some of the biggest challenges and opportunities to scale up the management of PPH that you identified from your survey results? What are some considerations and recommendations for implementers interested in these efforts? Over to you two. Thanks.
Thanks, Debbie. We'll have to talk very quickly. I think we saw a number of opportunities, making certain that the scope of practice for midwifery matches the updated guidelines. I think the other thing is to strengthen relationships regulatorily and also through professional associations in both the public and private sector. And, through that collaboration, I think there are huge opportunities for quality improvement through quality improvement processes, through strengthening referral systems. I think really that focus on public-private and enhanced collaboration is one key opportunity. So let me just turn it over to Gaurav for any final comments.
I think you've covered it well, Suzanne. Nothing to add from my side.
Thanks to both of you.
Gaurav. And thank you, Debbie.
No, thanks to all the presenters. This has been a great webinar. As they've said, we are going to be getting the slides and there's actually a recording that will go out to everybody who registered. Please make sure, add any last questions you have. We'll try to make sure they get answered. Really appreciate everybody who's joined. And I just want to give huge thank yous to MKA who helped organize it. The presenters, of course, were fantastic. Great, lots of great information. And a thanks to all of you for joining us. I think we've brought some important messages to everyone. I think we need to keep working on PPH prevention. We've got make sure we've got quality assured medicines and make sure we're working on the new evidence-based PPH bundle that we learned about through the emotive trial. And on induction and augmentation, I really ask that all countries really take a look at what's happening, no heads in the sand. Let's monitor. Let's find out what's happening in your countries. It's an issue everywhere. We don't understand the full, let's say, the extent to what is going on, but these are issues that we all need to be addressing. And with that, I turn it back to Francesca and the team for the wrap up. Thanks to everyone.
Thank you, Debbie. I will once again echo thanks to our presenters for those fabulous presentations. I learned so much about uterotonic medication. So thank you for sharing about your fascinating work on these topics. We will request that all participants do take just a few moments to fill out the survey evaluation form that's been shared in the chat, and our colleagues can share it once more in the chat just so you can see it again. So we would really love to hear from all 151 of you who are currently on the call. Your feedback is very important to us so that we can ensure that we're incorporating your feedback for future Momentum events. Do you also want to thank all participants for your time today, active participation. Thank you for sharing questions and keeping the chat very active. And with that, I will let everyone go. Thanks again for joining this webinar. It's been a pleasure to be with you.
Thank you.